And the good thing is that most of the patients do not require surgical intervention, though Dr. Monsef may not like it. Some of the potential generators in the lumbar spine are innervated structures and innervated structures. So for the innervated structures, it would be the bodies, transverse and spinous process, facet joints, external annulus, anterior longitudinal ligaments, and the interspinous ligaments, muscles, and fascia obviously can cause pain coming from the nerve roots. Some of the non-innervated structures include ligament flavum, internal annulus, and nucleus pulposus. So it is obviously very important to identify the actual source of pain, either through in addition to careful history and physical examination with some diagnostic procedures and maybe some diagnostic intervention procedures. Again, while evaluating a patient, it is very important to keep in back of your mind that there be more than other sources of pain other than the spine causes of pain, which may include dissecting aneurysm and especially in females, ID and sometimes the pregnancy or ectopic pregnancy can also cause pain. Please keep that in mind and try to refer to adequate, especially if you are suspecting. Again, while evaluating the patients, most of the times these red flags are not present, but always in the history of any nocturnal pain, unintentional weight loss, or bowel incontinence, and progressive motor weakness or gait disturbances. Again, Kodak syndrome is one of the neurosurgical agencies, and the results are much better if the surgical decompression is performed as soon as possible, preferably before 48 hours. So now I'll briefly and quickly run through some of the interventional procedures that are commonly performed in the outpatient and ambulatory surgery settings. As I said earlier, most of the low back pain patients or neck pain patients do not need surgical intervention. Some of the indications for referral or think about the interventional pain is failure of adequate conservative, including physical therapy, home exercise program, active rest, common medications including steroids, anti-inflammatory medications, muscle laxants, gabapentin, etc. Some of the patients can also benefit from interventional procedures include acute or chronic radicular symptoms, chronic axial back pain, compression fractures, disc herniation, discogenic pain, and ongoing pain after major spine injury that is called post-limectomy syndrome. Of the common procedures include the invasive procedures that are very safe, very rarely performed in any settings. They are the trigger point injections for myofascial or muscular pain, epidural steroids injections through different approaches, including the interlaminar, translunar, or caudal approach, medial branch block, acid-mediated pain, SI joint injection, and radiofrequency ablation or episiotomies. Some of the more advanced procedures include oculoplasty or annuloplasty, intradiscal procedures including discograms or the actions, spinal cordators, cutaneous or endoscopic discectomy, vertebral kyphoplasty for compression fractures, interspinous device for localized spinal stenosis, especially in the patient who are not a surgical candidate or too sick to have a major spine surgery, and interest for vertebrogenic pain. So epidural steroids injection, the epidural space can be approached either through the internal space, caudal, transforaminal, or it can be catheter directed. We can direct the medication to a desired level to get some relief. And each approach has its advantages or disadvantages. As far as the interlaminar approach is concerned, and probably it is done more commonly than the other type. Some of the initials include multi-level spine disease, spinal stenosis, and herniated disc with nerve root irritation. The advantage is that you are injecting the medicine through the interlaminar space into the epidural space. And then these are the structures that you would be going through, including the skin, subcutaneous tissue, uh, uh, latitudinal ligament, interspinous ligament, and the ligamentum flavum. And once you are in the epidural space, you are injecting the contrast material followed by a low dose of cortisone. So you can add the medication depending on volume at 2 to 3 levels, and depending again on the volume, spreads to the lateral and sometimes anteriorly as well. Again, it is a very safe injection, but there is always a risk of infection, bleeding, and spinal. Again, the series of 3, that is outdated. There's no scientific basis for it, and nobody does it. Even the insurance companies won't let you do it. So please not convey the message to the patients or that impression that you are going to 3 injections. So after each injection, the patient is re-evaluated depending on the previous response and the need for further injections. They are have another injection if needed. Epidural, most of the times, again, it is a simpler approach. It may be a little safer than the internal limb, but most of the times it is done in post-surgical patient. There is a lot of viscosity into the lower lumbar spine, and it is not practically possible grow through the scar tissue. Transforaminal actions are done mostly for the case involving 1 or 2 nerve roots. You can direct the medication along the nerve root, and as you can see in the lateral view, the medication also spreads anterior. So it is more specific, and probably will have a better response, especially in younger patients. It can be done both for diagnostic and therapeutic purposes, and you can also inject just the local anesthetic for diagnostic purposes if that is requested by urgents. Facet joint, another very common of axial back pain. Unfortunately, there are no good or relatable diagnostic tests that can identify exact source of pain. So for that, we can do the diagnostic median block in which anesthetic the sensory nerve to particular joint, and depending on the response, including the approximately 50 to 60% pain relief and movement in function for the duration local anesthetic. And you know that is the source, and this procedure can be followed by episiotomy or radiofrequency ablations. So sometimes basically these are the pain patterns for facilitated pain in the lumbar spine. We mostly in the lower back, and sometimes it can be referred the posterior thigh. More the times in the lower back, it would not cross the knee. Similarly, in the neck, these are different facet joints that can cause the pain. Sometimes shoulder pain may be coming from the cervical spine. So just keep that in mind, that all shoulder pains are not because of the shoulder pathology. These are some of the landmarks when you are putting the needles. You are trying to be close to those sensory to anesthetize the nerve and the particular joint. These are the fluoroscopic images, the targets where you would be or directing your needles. Similarly, in the lumbar spine, that target that would be for the medial branch block. This is the Scotty dog appearance that you would see in the fluoroscope in the oblique view. As I said, radiofrequency ablation we performed on the successful diagnostic medial branch block, and gives you longer reduction in pain. Most times, 6 to 9 months relief can be acted if you have been able to diagnose the source of pain. And this is another can that gives you a little bit of bigger lesion, so that if you are not very close to the nerve, you are still able to lesion the nerve. SI joint injury again are very common pathologies. This patient presents as pain in the lower back on the buttock area. Sometimes they confuse it with the hip joint pain because sometimes the patients say that I have pain in the hip. So you have to be careful, and they are talking about the hip. They are not talking about the hip joint. Again, SI joint is a very common source of pain, especially if the lumbar spine has been fused, especially the lower lumbar spine, because the SI joints are taking a lot of burden because the spine is fused. Again, discography is for diagnostic and therapeutic purposes. In most practices now, it done at the request of a spine or neurosurgeon. Basically, what we are trying to achieve is find the exact source of pain, so that can aid the surgeons in deciding which level to fuse. And it can be very useful in patients, especially the ones that do not have clear-cut pathology that can be demonstrated on the MRI scans. So effectively, what you are doing is that you are injecting a contrast material inside the disc, and if you are able to produce concurrent pain at a particular level that the patient does not know, it is done blindly. You are putting 3 or 4 needles depending on the site of suspicion, and inject the contrast material, and the patient has the concordant pain without which level you are injecting, then that will aid the surgeon in deciding that level of fusion. After the discogram induce the CT scan to classify the pathology. That is called Dallas classification or modified Dallas classification. Invasive technique that a lot of pain physicians are performing are the disc decompression. It can be a decompressor. And the other one is endoscopic or percutaneous dissection. Basically, the indications for these patients, these procedures would be in the patient who have minimal disc herniation, and they are not either as candidate for surgery or not interested in surgery. So basically, this is a disposable device, this small kind of cannula with 14 gauge needle, and it has a rotating movement at the tip. So once you are inside the disc, then you are activating it with the switch, and it rotates and cuts the disc material in this chamber. You can also use it for biopsy if needed, or if suspicion of infection or something there. So this is a basically larger picture of that. The other approach is endoscopic or penis discectomy. You can basically look inside the disc and chip few pieces so that the pressure is off. And after discectomy is done, you can do nucleoplasty or annuloplasty so that you can repair the annulus. This is how it looks on the scope. Basically, you are approaching the disc space. You are going in the middle, in the anterior and the lateral view, and you in the contrast try to see that disc and then you can slowly take away the disc material. So this is between 4 and L5 and L5S1. This was done at 2 different levels. Spinal cord stimulation is another technique. It is used mostly for the post-laminectomy patients, which the surgery has been performed. They still have pain. And the radicular symptoms, sometimes the axial back pain, the radicular or regular pain is better controlled by the spinal cord stimulation, though with the newer techniques and the stimulation patterns, and some of the pain or axial pain can also be modified. It also used in neuropathic pain from any source. CPS is another example where you can successfully relieve the pain with the spinal cord stimulation. It is done in 2 phases. One is the trial phase, and the second one is the permanent placement. After the trial for 5 days, patient has excellent pain relief. You can do the permanent placement. Permanent placement also be through the percutaneous or a surgical lead. So this is the surgical lead, the percutaneous lead. Most of the time, the top of lead is at approximately T8, T7 level, depending on the uh, pain pattern. Another technique is the intrathecal pumps. Depending on the pathology, it can be either clofen, mostly for the spasticity, or opioids for chronic pain, especially on people who are on high dose of opioids and would like to switch. Vertebroplasty are two other procedures are done for vertebral compression fractures. The only difference or the differences with vertebroplasty and chiroplasty is that you are in vertebroplasty, you are going inside the vertebral body and putting in the rent bone cement that reduces the pain, tries to stabilize the fracture, and kills some of the sensin inside the vertebral bone when it heats up. In blepharoplasty, what you're doing is, in addition to putting the cement or before putting the cement, you are also trying to restore the height of vertebral body. The results are slightly better with blepharoplasty, but depending on the age of the patient and other comorbidities, it may be safe to do the vertebroplasty, the quicker procedure. So this it looks like. Once you have restore height, then you can put in the seam. So this would be the result. Vertiflex is another minimally invasive procedure that is done for 1 or 2 level of lumbar spinal stenosis. What you are doing is you are putting a device, interspinous device. That is how it looks in the image. So you are going in the interspinal space percutaneously, with little bit of sedation and look static, and opening it up. So basically, that spine in slicer and opens up the space. So this diagrammatic representation that may not be exactly true, but you can see the tightness in this area, and putting the device, the space opens up, takes away the pressure from the nerve. For the last 5 years, the thought process has changed from earlier. The thought process was that lot of pathology or the pain is generated from the lumbar disc, but now there is a thought process that vertebral end plates can also cause pain. So it is there are modic changes on the MRI scan, and what you can do is you can do the radio ablation of the basovertebral nerve. So basically, what you are going is going into the pedicle inside the vertebral body and ablating the nerve, and you can pretty much do one or two less at the same time, and the results have been very promising. So that is something to consider if your patient has not responded to other modalities. It's been treating them for 6 months, and there are modic changes on the MRI scan. This is called interest. So basically, this is what you are doing. Any questions? Thank you. So basically, these are the procedures that we routinely perform, help patients back pain or the neck pain. Thank you.
think it's
Thank you, Agarwal, for this very comprehensive view of interventional pain management. It's my pleasure to use our speaker now, Dr. Jarbu Monsef. Dr. Monsef, spine surgeon and assistant professor in the Department of Orthopedic Surgery and Rehabilitation Medicine at SUNY State and One Brooklyn Health. Originally from Beirut, Lebanon, he completed his orthopedic residency training at the University of Illinois in Chicago and his spine fellowship at Mayo Clinic in Rochester. Dr. Monsef has particular interest in ethnic and racial disparities in cervical myelopathy, optimization of bone and muscle health, as well as machine learning applications for spine care. Without further, I'd like to invite our speaker, Dr. Monsef, to address everyone.
Thank you. Good morning, everyone. Thank you for having me. I'm going to be talking briefly about multiple degenerative conditions that you probably see most commonly, and how we approach them surgically, what might be useful to you in terms of the patient population that you see. Mainly, if I leave you with one point of never missing a cervical myelopathy, then that's a successful talk for me. I'll start with a case that first walked in my clinic, was my first patient, and she was 54, and she had severe issues with her dexterity and balance, and one of her extremities was almost impaired with swelling, numbness. Her MJOA score, Modified Japanese Orthopedic Association score, which is one way of trying to qualify people's disability with myelopathy, which relies on upper extremity, lower extremity, bladder and bowel and gait, was 13 from 18, which is moderate. Grade, which is a way that we use to classically quantify myelopathy, with 3, and then the main thing about a 2 or between the 2 or 3 is a severe impairment, even beyond the ability to perform a job. So grade 3 is a medical issue where someone has no enough balance, not enough upper extremity strength or dexterity to perform their job, and she had a decent amount of pain, which is what we say neck disability index. Trays, she had nothing out of the ordinary. You see a lot of spondylosis in the subaxial spine. Usually that's where it's mostly concentrated. Spine is a mobile segment attached to a very stiff segment attached to another mobile segment. So because the thoracic spine is so stiff, the closer you get to it from the top, the closer and the lower you go, and then the large spine, the loads increase. And that's where the spondylosis happens most commonly. So most will have some spondylosis at the lower part of the subaxial spine. Thing out of the ordinary here, the fact that extension, she can barely go to a straight position, and in weight bearing is in kyphosis, which is bad for one reason, and that's that you have kyphosis. It's kind of bringing the spinal cord closer to all the anterior pathology. If you look at the eye, she has severe multi-level disease, but what jumps out most is when you look at it, you can see that this spinal cord takes up most of the space in the canal already, and that's congenital stenosis. So it doesn't matter that she's 50 or 5. If someone has a canal that's barely the size of their cord, then the minute disc bulges, which happens everywhere in the spine, then you get a very bad situation. Not because the pathology is different, just because the location, the worst possible location. Because at 3-4, none of your cervical roots even exited, and all of your brachial plexus has to come out between these levels. And if you look at the level of stenosis that she has, you can even start to appreciate a little bit of whiteness here, more on this cut there, which is myelomalacia, which is basically swelling of the cord. Use water in the cord on the MRI, means that it's swollen. Does it mean it's damaged? Maybe. Will it come back? Likely. So if you look at the axial shots, see every level, look where the green is. So this is at 3, 4, 2, 3, you barely see any problems there. You shouldn't, unless there's a problem. Here, 3, 4, 4, 4, 5, 5, 6, you can see this black disc or disc osteophyte at this point, because it's definitely not just this, how it's digging to the cord and then pushing the cord into the back of the lamina there, and 4 bad levels. So this is a very tough situation, because this is a physical problem. This is the worst level, and this is the biggest it's ever gonna get from this point on. So this is a pebble in your shoe, and it's already really into the soft tissues, and the pebble is only gonna get bigger, and your shoe is only gonna get smaller. That's what arthritis is. So she's 54, she's already severely impaired, and what do you do next? The caveat is, if you operate, you can pretty much say, I can stop your symptoms getting worse, but I can't reverse them. And if anything is reversed, then that's a bonus. That's why the most important thing is the time they get the surgery. Because if I can only freeze you in this version, then it better be the version. And that's determined by the time they walk into the clinic. So she ended up, and on the CT scan, by the way, you can see this, what looked like a disc is disc osteo. So you actually have pure bony stenosis. This is the actual size of the canal. Nothing stands a chance to that. The cord is very malleable, and sometimes it goes down to half of it really is. So she was my first case. I ran this case by many of my mentors, and everyone agreed that it has to be one surgery to take care of her entire cervical spine, especially with the presence of myelomalacia. The worst thing you can do to her is to save level and then come back and find that level is causing more damage. Especially, you can't really detect the damage. So we did a 4-level anterior, because we want to get all these discs, 1, 2, 3, 4, and you can go after these discs in a very good way from the front of the neck, because unlike the lumbar spine, unlike the thoracic spine, the cervical spine is easily accessible. So you go in, you cut disc out completely, you get the pressure off the cord, and I'll show you a little bit of pictures, and then you put these cages in, and the bone will grow through these cages and cause the fusion. Now, there's a technical point for going posterior this situation, because 4-level anterior constructs are not able on their own. They change the way the spine works. So we'll cover that. This is the reason why we go from C2 to T2. It's because C2 has the best bony purchase, and you don't stop at a junction. So C7, T1 is somewhere, won't stop, and there's no point in saying a 2, 3 that you only address in the back, and then you're gonna create a problem here. So a C2, T2 is the most comprehensive way of making it a one and done procedure. And she woke up with a C5 palsy, actually, and she go walk normal, and then the next day she had 1/5 bicep eccentroid on one side, but the symptoms had resolved completely in the other arm, and it was fully functional now. And the C5 palsy lasted for 10 months and then resolved spontaneously. Now she has a 5/5, and she did very well. So the normal canal, usually in normative studies, has been measured to around 16 to 18 millimeters in size, from the back of the bone here to the front of the bone here. Now people are born with 10, 8, 12, and the degenerative process brings that size smaller. The size of the canal narrows down as you come from T2, 3. You can see how big the size here is, and that's why when you get trauma, E1 or C2, usually it's not a problem. You have a big canal, and usually that trauma makes the canal wider, but you see how it gets narrower in the subaxial spine. These are discs. These are what good discs look like, and then this is where the flavum is. You can get anterior pathology. You can get post pathology. It's important to note that the nerves and cervical spine exit their respective pedicles, which is why we have a C8 nerve which exits above the T1 pedicle. And so whenever you're dealing with compression, if some passes centrally, it will affect the cord, and then everything below is fame. The only thing that can't be affected is what has already did. And that's why a C3 pathology will everything. 2, 3 will affect everything. 4, 5, maybe if the 5 root is left, you can get shoulder. And for the purposes of ruling out shoulder versus neck in every patient, shoulder is mechanical. Stop the shoulder, put some resistance. If it hurts, it's shoulder. If it's the neck, it should hurt at night. It should hurt when you're not moving. It should hurt when it doesn't make sense mechanically. So most people have shoulder pathology. Very few have neck pathology. But what makes this more difficult is that the pain generators in the neck, just like Dr. Agarwal covered, are not entirely fully understood. So the causes of pain can be discogenic, they can be facetogenic. You can get off disc herniation that turns into a hard disc and then osteophyte. And this is exactly what we remove when we go in for an ACDF. You cut out, you follow this, you get it off the cord, and then you hope for the best. You can't do anything to the cord. It has to heal itself if it can. Now this is what starts happening. You start losing height. These become hard bone. You also lose the alignment. Can get contribution from pathology, back of the flavum, posterior pathology. So there are different pathologies. Most people have arthritis or spondylosis in their neck. By age 70% of females, 95% males. So it doesn't matter. The disease doesn't matter as long as it's regular, degenerate. Okay, perfect. Sometimes see ossification of the posterior longitudinal ligament, which is important to know if you're going in anteriorly. And this is what it looks like in varying degrees. Loss of disc height. This is where you can get modic changes, bone on bone changes, and then you see the collapse of the disc base, and then here all the way to myelomalacia. As we said, most on C5-6, C6-7, C4-5, those are the most mechanically used levels. Risk factors for spondylosis. So what the question I get the most in clinic is, what can I do to stop arthritis? Nothing. You can't really do anything to stop the arthritis. You use things to make it worse. So you can smoke, have horrible posture, have malnourish yourself, especially with protein, do bad things that can hurt you. And those things accelerate the aging process. If you do them well, you can reverse it, but that's all you can do. In terms of cervical stenosis, we use numbers not like 10 or 3 millimeters. What really matters is how much there's space available for the cord. This is a very severe case here. Usually, the clinical lens and the symptoms don't have to correlate. You can see a picture like the patient walking into clinic. You can see patients with much less compression. They're much less functional. But what is sure is that all these patients are a sneeze away from either central cord syndrome or full paralysis. They're either a fall or tumble, or some people even less energy can cause to really hurt their cord. If they go under anesthesia for an appendectomy and you don't know that they have this much stenosis and then the neck is extended, they could wake up paralyzed as well. That's why we do these cases under monitoring. The main reason for cervical radiculopathy, which is only affecting the nerve root instead of the cord itself, mainly has to do with how the oncovertebral joints hypertrophy. The vertebral joints boats that hold the disc, and they kind of hypertrophy from the front and from the back, and they tighten up the space, so you get the nerve getting squeezed between that joint and the oncovertebral joint here. This is very well addressed in anterior surgery because you can sneak behind here and then remove this bone, and some surgeons can address it from the back with a foramen, which is also done minimally invasive. Now, what patients present with most of all, pain. And referred pain is very common in the cervical spine, and it's extremely important to note this. Dr. Agarwal showed this shot. And this is a study where they went in and they gave blocks in these facets, and they found that the pain relief was correlated to these areas. So a lot of people with neck pain have pain in the back of the head, behind the skull, but more importantly, the lower subaxial spine, 6, 7, and 7-1, can even refer to the front of the chest, to the left side of the chest, and those people, they're referred to as cervical angina. If you rule a heart issue and you find that, you can even send them to interventional pain, put a needle in it, and figure out if this is the reason for their pain. And if it is, it's a very scary thing, because these people have real chest pain that doesn't show on any test. So referred pain is an extremely common reason for the patient disability. And it's very important to tell them that it's likely that when we fuse a level and we get the motion at that joint, that you might feel relief. But then again, in myopathy, it's not the main point of the surgery, and you might still have pain. This is the actual data from the study itself, showing how different facet injections correlate to pain relief in different referred distributions. And so basically, neck pain, common in everyone. The two things that you could have is compression of the spinal cord, compression of the nerve. Compression of the nerve is radiculopathy. Usually, it's a disc herniation in a young person, arthritis in an old person. Myopathy can happen at any age. And the thing about it is, be subtle signs that the patient is overcoming, and you need to push them a little bit to figure it out. You see long thorax signs if you sometimes it's a little bit late, and any reason can cause myelopathy. We're just talking about degenerative reasons here. This is what it looks like when you have a disc herniation. You can see here there's not a lot of space. And then this is what the disc looks like, pressing the cord. This is what it looks like, and it's multi-level and severe disease. This is a paracentral, but then when it touches the cord, it will cause myelopathy. You can have them present with lower extremity symptoms and no upper extremity symptoms. I've had that before. And for the radicular symptoms, I don't know if you guys get tested on this, but the C5 is deltoid and biceps, C6 wrist extensors, C7 is mostly tricep, wrist and finger extensors, and then C8 are the hand intrinsics. It's very hard to gauge somebody's intrinsics. Use a grip strength tester, a dynamometer, because it's hard to know if a person if a dominant hand is as strong as their non-dominant hand, then the dominant is a 4. You're already suspicious. If they can't walk in a tandem gait, which it could because of hip pain, but for any reason, can't walk in a tandem gait and have a little bit of grip strength, that's your earliest cues. And you should be testing those things on everyone. Ask them about dexterity. Are you dropping things? Are you unable to cut your food? Things like that. They'll tell you. They'll tell you that I'm hanging on stairs and I can't open the doors, but I've been doing it for years, and that tells you how they've been compensating. In terms of neuropathy, you can manage their pain, you can deal with numbness. The only reason I would tell someone needs surgery is when you start having weakness or progressive symptoms. Otherwise, most of the time, if it's a disc, inflammation around the disc get better. You can give steroids, you can give injections, you can give NSAIDs. At the end of it, time will help most of those cases. So unless you have weakness and aggressive issues, that's fine. Again, there's a lot of things that can confuse the upper extremity. There's nerve entrapment syndromes, and this is pretty low yields for you guys. And the myelopathy, when you start seeing these patients with progressive symptoms, I think, what can I be missing that is not myopathy? Because I'm looking for myelopathy. You guys are looking for anything else. You're looking for ALS, multiple sclerosis. So you have to ask yourself, what if it isn't those things? Like I ask myself, what if it isn't myelopathy? So just keep an idea. It could be a medical reason. It could be a purely mechanical reason for what you're observing. They can have illness, they can have headaches, I want to show you a little bit about what the surgical treatment options. So this is for acute radiculopathy. This is called a keyhole foraminopathy. You can go in the anterior aspect of the cervical spine and then create a small hole in bone and clear off pressure off of the nerve. This is a very simple procedure. Don't burn any bridges. You can go back and do the surgery if need surgery, and this is good when somebody's trained to do this procedure very well. In terms of myelopathy, you also have to keep in mind it's a dynamic stenosis. So sometimes on the eye you might see enough space, but when they stand up and they load, it looks different, especially in terms of the vascular compression of the cord. It doesn't have to compress the cord itself, but if you compress the vascular supply to the cord, you start having those changes, and that's why people with such severe stenosis sometimes do so well, because the stenosis happens so gradual that they deal with it. If you were to close down that space in 2 seconds rather than many years, they would be paralyzed instantly. But it's only because time held out. A lot of times you see something like this: diffuse idiopathic hyperskeletosis or skeletal hypostosis or ankylosing spondylitis, or a lot of calcification. Sometimes the body actually fuses some of those levels, and if there is no compression there, then that's fine, but most of the time there is. And then sometimes you see ossification of the longitudinal limb. You can see here this black thing behind the body on the MRI. You can only see bone on a CT scan, but you can see very dark shadow, and that suggests a longitudinal ligament being ossified, which is important to know if we're going after from the front. So covered all main symptoms of myelopathy. At some point, it can come to urinary spasticity, but hopefully, they're operated on before. Not everyone has back pain, and not everyone has a positive Hoffman hyperreflexia. They could, but if you have central stenosis and foraminal stenosis, the foraminal stenosis can take away a reflex. You could be hyperreflexive and hyporeflexive and then normal. So you can test, you can rely on physical exam, but mostly the history. The history tells you everything. Tandem gait is very important. How many steps can they take? Pronator, Dromberg, heel to toe, the tests. Make sure you're not missing any other reason. You can test also their grip and release, how fast they can do it in 10 seconds. And these are some typical signs. Their meat is when you bend their neck, flex their neck, or extend their neck, and they can trigger some electric shock and a cape light distribution. Hoffman's is a sign of hyperreflexia, and ankylosing is also a sign of hyperreflexia. Now, ALS, MS, B12 deficiency, they should be on the differential with this group. And then we're not going to talk the classification for the sake of time. I want to show you the natural history of myelopathy was studied in the 60s. They described a progressive stepwise deterioration. Progressive stepwise deterioration is a word to use with these patients. You can see here, this is a cohort of patients followed with very good metrics: dexterity testing, grip strength, filament testing, gait testing, and a lot of outcome scores. And all is here. And you can see two kinds of graphs. One, the blue graph, which is patients who are diagnosed with the myelopathy, who are getting new levels, and then these ones were with primary diagnosis. You can see the theme is progressive stepwise. So they just go down, just lose something, and they stay there for a while, and they say, okay, I'm managing now, I'm using my right hand cook, and then in 2 months they say that they can't cut with their right hand. Now I have a healthy fade. Now I'm using a walker instead of a cane. That's how these things have to happen, and you can't take them back a step. You can only save them where they are. So the approach, best case scenario, I can give you only an anterior approach. Anterior approach is the best. It doesn't have a lot of morbidity. You can access the pathology almost always directly. There's no pain. There's mostly dysphagia. You move the throat to the side, and then you put your finger down. You're just looking at the cervical spine. You go between the carotid sheath on one side and trachea and the esophagus on the other. As soon as you pose here, you box yourself out so that you protect you from the esophagus, and you're looking right at this view of the cervical spine with these discs as both. And all the entire surgery is a microscope, so it's important to keep yourself in orientation, box yourself out, and you can see here, this is the vertebral body, that's the vertebral body. You take the disc, you go all the way to the posterior aspect where the disc is on the spinal cord. Use a burr, you can use different sizes, spoons basically, and then after you're completed with the decompression, you can put either a piece of bone, piece of metal, and then most of the time we put on plate, you achieve fusion. Sometimes there you can do a screw placement, not in myelopathy, but in certain radiculopathies, and there's not a lot of disease. When we go posterior approach can decompress in a different way. You can't really access the disc in the back. This is a view of the head on the side here, and the legs on this side. You have C2, 4, 5, 6, 6, and 7, and this is what it looks like when you use the posterior cervical spine. You have the little masses here, which is where your screws, and when you want to decompress, you basically burr off the bone here, and in one line, you burr off the bone there in one line, and then you can lift off the bone and just have the spinal cord drift back at you. Now, this only works if the spinal cord can drift back at you. And that's why if the neck is in a lot of flexion, then the spinal cord is not going to drift back because it's draped over the disc, because it has the head here and the legs are here. So as long as the neck is straight, or in public is 14 degrees of kyphosis is even okay. Anything beyond that, you have to go through the front only for mechanical reasons, to straighten out the neck. And if you can do it from the front, then that's fine. If you have to go back posterior, then you go for front and then back. And that's why there isn't like a one-size-fits-all surgery for these people. Some pathology is posterior, like it's the ligamentum flavum. But here, if the disc is digging into the cord and it's draped on the disc, it might still not be enough. But this is what it looks. You put the bone here, you put the bone graft here, and this entire thing will become bone, hopefully. And this is what I was talking about. When you have a normal alignment, is where the cord sits. If you have a kyphotic alignment, the cord is being draped over the front structures. And then if you do a laminectomy, the cord is going to stay draped over the front structures. And that's why you have also a section of the posterior longitudinal ligament. If you look at it on the CT scan, it looks like a flowing candle bone. And it's something that you can't really dig into, because this adheres to the dura. If you remove it, that can get a dural leak and complicates things. So usually we try to avoid opial by going posterior. This is what we position the neck in, usually a Mayfield head hole. When we're doing the posterior cervicals, you can adjust the position of neck intraoperatively, especially after the decompression is done. And also, you see the electrodes for the monitoring. They're running SSEP, so somatory evoked potentials all the time, and they can tell you if you see improvement in the amplitude or in the frequency of the signals. I think that should be enough. This is a bit much about mechanics, and we'll have to go front and back. That's it. Any questions? Thank you guys for your time.
Hi, everybody. Can you guys hear me?
Yes, we can.
Okay, great. I just have a moment. Really amazing talks. As I've mentioned in the past, Dr. Monsef and I have been working very closely together. We'll continue to work closely together to expand the volume of cases that we're hoping to manage at downstate and not have transferred out unnecessarily. As Dr. Monsef mentioned, for the residents, very important always to keep the differential diagnosis in mind. So not only do you want to get better at identifying and properly referring a case of cervical myelopathy when that exists, but keep in mind other pathology that can result in, for example, an expanded spinal cord parenchyma relative to the spinal canal. So, tumors, intraparenchymal tumors, intramedullary intraparenchymal tumors can expand the cord. Syringes can, syrinx of the spinal cord. Remember NMO. You want to protect your surgeons from operating on NMO. So, have a high index of suspicion for that if you're getting visual symptoms as well as symptoms referable to myelopathy in the cord, inflammatory causes of cord edema, etc. So always keep that differential diagnosis in mind. I think that's probably the primary thing that I'd want to contribute. But I'm really glad I was able to catch this. I can't stay on any longer. But glad that we had Dr. Agarwal and Dr. Monsef today. Okay, so take care, guys.
Thank you, Dr. Bartal. Thank you for joining, everyone. Thank you for your time. Thank you, Drs. Agarwal and Monsef.